refers to the closeness of a measured value to a standard or a known value, whereas precision refers to the closeness of two or more measurements that are measured to each other. Right. So let us try to understand this with the help of a figure. As you can see here, in the left, from the left, the first figure has measurements that are both accurate and precise. The second figure has measured values that are close to the set value, but they are not close to each other. So they are accurate, but they are not precise. In the third figure, the measured values are close to each other, but they are not close to the known value. So the measurements are not accurate, but they are precise. And in the fourth figure, the measurements are neither close to each other nor to the set value. So they are neither accurate nor precise. Ideally, if you want your study to have minimal error, the results should be both accurate and precise. Now let us try to see what accuracy and precision looks like in the graphical form. As you can see in these figures, in the first figure, the data is spread out and it is away from the set value. So it has both low accuracy and low precision. In the second figure, the data is close to each other. It has less variability, but it is still away from the known value or the set value. So it has low accuracy, but it has high precision. In the third figure, the data has high accuracy because it is close to the known value, but it has low precision. And in the fourth figure, as is the ideal condition, there is both high accuracy and high precision. Now let us talk about validity. Validity in research refers to the degree to which a study accurately measures the concept that it is actually supposed to measure. So it is an indication of how close the study findings are to the truths or the actual situation. Right? There are two types of validity: internal validity and external validity. Internal validity is the integrity of the experiment. So it refers to the extent to which the study accurately measures, and it measures free from bias that what it is supposed to measure. And external validity is the ability for the study to generalize its findings in the population at large. Let us try to understand this with the help of an example. So if I'm conducting a study that is supposed to find the association between C-section and postpartum depression, so can any of you tell me what will help? What will be the internal validity in the study, and what will be the external validity in the study? You all can unmute yourself and answer, or you can put it in the chat box. Would anybody like to answer? Okay. So as you can see in this figure, the internal validity is the truth in the study. So here the internal validity will be how accurately I am able to measure the truth association between C-section and postpartum depression. And external validity is the truth in real life. So external validity is how accurately the results of my study can be transferred into the population at large. Now let us talk about errors. In epidemiological studies, an error refers to any deviation from the true result or findings which can affect the conclusion that we draw from the study. Okay, I will decrease my speed. Does anybody want me to repeat anything that I have stated before? If you want, please say so. Now let us talk about errors. In epidemiological study, an error is any deviation from the true result or finding that can affect whatever conclusion we want to draw from the study. So these errors are harmful because they lead to inaccuracies in estimating the association between exposure and the outcome that we want to measure. In epidemiological studies, errors can be random or they can be systematic. Systematic errors are further cut down into selection bias, measurement bias, and confounding bias. First, let us talk about random error and systematic error. Random error or random uncertainty comes from fluctuations in measurement that can be greater or less than the actual result. So, for example, these depends on like if you are reading a scale imprecisely, something like that. Right? So these errors stem from limitations or of whatever equipment you're using or the limitations of the experimenter themselves. These errors, you cannot ever eliminate them completely, but you can reduce random error by using by repeating your measurements or by using larger and larger samples. On the other hand, systematic errors always affect the measurement in one direction only. They are either because of an instrument that has been incorrectly calibrated, for example, a weighing scale that is giving either too high or too low readings, or because of some error from the experimenter. For example, parallax error. Parallax error is when you are reading the volume of a liquid and you are reading it not from the eye level. So the readings will consistently be too low or too high. Systematic errors can be reduced by good experimental design, and systematic error is what we will be focusing on today. Systematic errors are also called biases, and biases are any errors that can result in the incorrect estimation of the association between the exposure and outcome. This is what we will be focusing on for the rest of the PPT. There are main three types of biases: selection bias, measurement or information bias, and confounding bias. First, let us talk about selection bias. Selection bias is the most common type of bias in health research. It occurs when the study sample is not a true representation of the population at large, and it threatens both internal and external validity. Let us try to understand what I'm trying to say with the help of an example. So let us say that there is a study to look at the association between C-section and undiagnosed postpartum depression. Right? The subjects taken are women who have given birth via C-section. What bias can occur here is that women who experience more severe PPD, they would be more likely to seek help from certain mental health professionals. And on the other hand, those who have less severe PPD, they are less likely to report their symptoms. So they are at a higher risk of going undiagnosed. Therefore, the women included in the study, they are more likely to have milder cases of PPD because those with more severe symptoms are anyways more inclined to seek help from mental health professionals. Therefore, as a result, the study will can show a weaker link that exists between cesarean delivery and PPD than what actually exists. Right? This is a general example of a selection bias. Now we will look at the different types of selection biases. First, there is volunteer bias. In a volunteer bias, what happens is that when participants select themselves or volunteer themselves for study, those participants tend to do so either because they are more unwell than the population at large, or because they are more worried or more health conscious about the exposure or about the disease. So that is not a true representation of the population. So that can lead to skewed results. For example, if I'm doing a study to look at the effects of a particular prenatal vitamin and its effects on pregnancy. So volunteers for this study are more likely to be more health conscious because they want to know that what are the effects of this vitamin on my pregnancy outcome. So the results can be skewed in one direction. Then let us look at the another bias, that is non-response bias. This occurs when individuals who don't participate in a study or a survey, they differ in significant ways from those who do respond, which can again lead to skewed results. For example, the women who have STDs, they are less likely to fill a questionnaire about STDs compared to women who don't, out of shame surrounding the topic. So that can lead to different incidents or different prevalence of STDs reported in the study than what is actually present in the population. Another type of bias is exclusion bias. This occurs when certain individuals or groups are systematically left out of a study or analysis, leading to unrepresentative results. For example, if I'm doing a study to evaluate a new drug for treating PCOS, researchers, I can exclude women with obesity because it can lead to potential confounding factors. But this exclusion bias can lead to misleading conclusions about the effectiveness of the drug, as the results don't reflect on how this drug acts on PCOS patients who are obese, which constitutes a large population of the PCOS patients. So this can lead to exclusion bias. Next is healthy worker bias. This states that healthy people remain workers, whereas those who are unemployed, they could be either retired, they could be disabled, or for whatever reason, they are out of the work population, they are generally less healthy. Therefore, there is always a bit lower mortality observed in the employed population compared to the general population, because the general population includes the employed and the unemployed population. If anybody has any doubts up till this point, please feel free to unmute yourself or put a question in the chat box. Okay. Now let us talk about survival treatment selection bias. This bias occurs when the selection of treatment is influenced by the prognosis of the patient, because it leads to distorted. Okay, somebody has a question on internal and external validity. Wait a second. Do you want me to like the difference between the internal and external validity? Want me to explain that? Okay. Validity, basically, what validity says that it is the degree to which a study accurately measures the concept. So if I'm trying to see if factor A affects disease B, so I'm designing a study based on this concept. So how accurate my designing is, or how accurate my results are, that is the validity. So it can be of two types, right? Internal validity is the integrity of the experiment. So if the experiment itself is accurately designed or not, if or it, does it actually or accurately represents how factor A affects disease B, that is internal validity. And external validity is my ability to generalize. So for example, if I'm conducting a experiment, I'm conducting a study on PIS patients in Ahmedabad. So the results of my study, can they be replicated in Mumbai, or can they be replicated in Delhi or in USA? So, or like in just the population at large. So if that is true or not, that you can figure out by external validity. I hope that answers your question. Does anybody have any other doubts about any of the errors that we have discussed till now? Okay. Moving on with the topics, we were talking about survival treatment selection bias. So this bias states that the selection, when we do the selection of a treatment based on the prognosis of the patient, this bias can occur. It will lead to distorted outcomes in studies, because patients who are destined to live longer, they have more opportunities for treatment. So the treated patients, they appear to have better survival than the untreated patients. Let us try to understand this with the help of an example. So let's say I'm conducting a study comparing surgery and radiation therapy, both as a treatment for cervical cancer. Right? If I only include patients who survive after the treatment, I may find that surgical patients have better outcomes. But this could be misleading, because generally healthier patients are more likely, if we base our treatment on prognosis, healthier patients are more likely to get surgery as a treatment. Whereas those who have a more advanced cancer, or those who are of a poorer health, they could be given radiation as the therapy. So the results don't accurately reflect the efficacy of the treatment. Rather, they can reflect the underlying health of the patient. This is what survival treatment selection bias is. Now, let us talk about Neyman bias, also known as incidence prevalence bias or selective survival bias. This occurs when studies exclude cases of patients who have already died or recovered, because this leads to a misrepresentation of the true relationship between the exposure and the outcome. This bias can change the results, because characteristics and outcomes of existing cases are very different from those of new cases or of those cases that we have excluded. Let us see an example. In a study that looks at the link between gestational hypertension and pregnancy outcomes like preterm birth or stillbirth, Neyman bias can occur if only the women who are currently attending prenatal care are included, while severe cases like those who have stillbirth or those who have a miscarriage, they are excluded, because this emission will uh, exclude the cases who have higher risk or the true risk of this disease, as only the milder or surviving cases are analyzed. So this will lead to a distorted understanding of gestational hypertension's impact on pregnancy outcomes, like preterm birth or stillbirth. Now let us look at Bergson's bias or Bergsonian bias. This bias occurs due to differential rates or differences. Can you please explain the difference between random and systematic bias in your own words? Okay. Random bias is bias that become. Just a second. Let me open the table. So if you want to look at it, you can look. Okay. Random error is error that is just because of some kind of randomness. Like if I'm trying, like if I'm measuring the abdominal height of pregnant women, so if I did not measure it properly, or if I was not paying attention, right? So, or if the equipment I'm using is very faulty, so that is something that is like very random. It is not that always if the equipment is random or if the equipment is faulty, so it always won't be just in unidirectional change. It can be either less than or greater than the actual result. That is what is random error. And systematic error is the error usually in the instrument itself, or error, what we usually study is error in the study design itself. So, like we saw in, for example, let us talk about the first example we talked about, this selection bias, right? The association between C-section and PPD. It's a because the women with more severe PPD, they did not take part in the study. So the change that was in the result, that was unidirectional. You will always see a weaker link between the two, exposure and the outcome. So when there is such a unidirectional change because of some flaw in the study design or some flaw in the calibration of the instrument, that is a systemic error. That is a problem in the instruments we are using, whether that be some measurement tool or whether that be the study design. And random error is mostly just human error that can occur. I hope that answers your question. Okay, great. Yes, we were talking about Bergson's bias. Right, so this bias occurs because of differential rates or probability of hospital admission between. Sorry, uh, yeah, we were talking about Bergson bias. This bias occurs because of differential rates or probability of hospital admission between two groups. And this is produced when the probability or possibility of hospitalization in the case group and the control group differs. And thus it is also influenced by the exposure. Let us try to understand this by an example. It's a study is done to determine the relationship between hormonal contraceptive use and the incidence of pelvic inflammatory disease, that is PID. If the researchers decide to recruit participants only from a fertility clinic or a hospital, where women with pelvic inflammatory disease are more likely to come and seek treatment, so the study will overrepresent women with severe disease. This could lead to a misleading conclusion between the association of hormonal contraceptive use and PID. Because the sample doesn't reflect the general population, it only reflects the population of the women who come to the clinic. This is Bergson's bias. So this was all of the selection biases. Now let us talk about how we can reduce or how we can control the selection bias. So we can reduce selection bias at two phases, either during designing the study itself or during analysis. During study design, we can reduce selection bias by randomization, restriction, and matching. And during analysis, we can do so with the help of stratification and multivariate analysis. So what is randomization? Randomization is just that the subjects of the study are randomly selected to even out any unknown co-founders or any unknown factors that we are not taking into account. What is matching? So for each patient in one group, there is one or more patients in the comparison group with the same characteristics other than the exposure and outcome that we are matching. For example, matching, if you are taking a case and a control group for, again, checking the relationship between C-section and postpartum depression. So we will do matching in both the groups for age, race, and sex, so that all of these other variables are taken into account. What is restriction? The subjects chosen for study are restricted only to those who have a very narrow range of characteristics that we can then study and analyze. This is basically the inclusion and exclusion criteria that often goes into studies. Right? So, for example, if I'm doing a study on uh, women of reproductive age, I will, if I want to, I can restrict the study to women having at least one child, so that there are less factors to take into account. What is stratification? This is the process of separating a sample into several subsamples according to some specified criteria, such as age group, socioeconomic status, etc. And what is multivariate analysis? So this is the statistical analysis of data that is collected on more than one variable. For example, age, body weight, body fat, cranial capacity, etc. These are all of the ways, methods that we can implement to decrease selection bias. So this was all about selection bias. Now let us talk about measurement bias. Measurement bias occurs when there are systematic errors in the way that data is collected, measured, or classified in a study. Let us look at the types of measurement bias. First of all, there is interview bias. So, an interviewer's knowledge can influence the structure of questions and the manner of presentation, which can further influence the response of the participant. For example, if I am doing a study to investigate the effects of prenatal care on maternal outcomes, interview bias can occur if I unintentionally or unconsciously ask leading questions that can uh, further influence the participants' response about their experiences with prenatal care. So, when the interviewer is asking a question, they need to be unbiased and wary of this type of bias. Then there is recall bias. So those with a particular outcome or some kind of disease, they can remember their events much more clearly compared to those who did not have that exposure or that disease. For example, if a mother has a baby born with some kind of congenital disorder, she will remember every event of the pregnancy much more clearly than a mother who doesn't have this baby with a disorder. Then there is reporting bias. Participants can collaborate with researchers and give answers in the direction they think that the reporter wants, or that they think that are of interest to the interviewer. For example, if I'm doing a study assessing the association between maternal smoking in pregnancy and low birth weight, women who smoke, they might underreport their smoking habits because of social stigma or because they think that the researcher or the interviewer doesn't want me to say, okay, okay, I have been smoking this much during my pregnancy. So this can result in an inaccurate estimation or an underestimation of the true impact of smoking on birth outcomes. Then there is attrition bias or loss to follow-up. This accounts for all those that are lost to follow-up or those who withdraw from the study. Those might be very different from those who are followed for the entire study, which can again lead to skewed results. For example, if there is a study evaluating the effectiveness of a new prenatal care program, attrition bias can occur if the women who drop out of the study are of a higher percentage with high risk pregnancies compared to those who stay in the study. Most of them are with low risk pregnancies. So this can skew the results. Now let us talk about surveillance bias. Surveillance bias states that the group that is known by the researchers to have the exposure or the outcome, they may be followed up or they may be checked on more closely and for a longer duration compared to the comparison group or the control group. For example, surveillance bias can occur in a study of endometriosis, where if the researchers know that the group is a group of women with a known diagnosis of endometriosis, so they can receive more frequent and more detailed pelvic examination compared to those without the diagnosis. So this can lead to an overestimation of the association between certain symptoms and the disease. Okay, somebody has asked me to explain interviewer bias with another example. Okay. Interviewer's bias, again, I'll just explain what interviewer's bias is. Interviewer bias says that the interviewer's knowledge can influence the structure of questions and the manner of presentation that can influence responses. So this type of bias is mainly for descriptive studies or studies that have long interviews with the participant. Right? So if I am the interviewer and I want to see the association between factor A and disease B, and in my mind I want there to be an association, so uh, unconsciously or unintentionally I can ask leading questions that can in turn cause the participant to give such answers that will show that okay, there is a higher association between factor A and disease B than there actually is. That is what interviewer bias is. I hope that makes you understand what interviewer bias was. And okay, somebody has asked me to explain name and bias. Name and bias is selective survival bias. Right? So, in a study, a lot of times, if it is some very severe disease, so if during the course of the study some patients die or if some patients recover, if we don't account for these patients and we only look for the patients who had the disease from the beginning of the study to the end of the study, uh, that could lead to a misrepresentation of the true relationship between the exposure and the outcome. That is what is name and bias. Let us once again look at the example. If I'm doing a study and looking at the link between gestational hypertension and the outcome like preterm birth, and if I exclude all the adverse outcomes like stillbirth or miscarriage, then I would be potentially excluding all of those patients with gestational hypertension who had a more severe outcome or who had a more severe case. And I would only be taking into account the milder cases because those cases survived and the patients gave birth successfully. So this could lead to a distorted understanding that gestational hypertension doesn't have that much of a severe impact on pregnancy outcome like preterm birth. That is what is name and bias. Okay. I hope that you had your question for name and bias. Did somebody else have any other questions or queries? Okay. Now let us talk about Hawthorne effect. Hawthorne effect is a psychological phenomena where individuals modify their behavior in response to knowing that they are being observed or being aware that they are part of a study or an experiment. Basically, people tend to act differently or tend to act better than they normally do if they know that they are being watched. For example, if I'm looking at a study examining the relationship between preterm births and bacterial vaginosis, Hawthorne bias can occur if women know that they are being observed and therefore they change their behavior. For example, women might adhere more closely to the health recommendations compared to what they would do without the study, which would lead to a misleading impression that bacterial vaginosis has a less significant impact on preterm births. And this could in turn result in findings that reflect that there is not that much of an impact or that there is not that much of a relationship between bacterial vaginosis and preterm outcome. That is Hawthorne effect. So this was all of the measurement biases. Can somebody recall what all measurement bias we talked about? You can unmute yourself or you can just like, I want you to name one of the bias that we talked about.
Interviewer bias.
Sorry?
Interviewer's bias.
Oh, very good. That is correct. Anybody else? Recall bias, very good. Okay, somebody asked me to explain name and bias again. Just a second. Uh, it would help if uh, the person who asked the question, if you could unmute yourself and tell on the chat box what exactly you didn't understand about name and bias. Hafsa. Example. Okay. If, for example, I'm looking at a treatment for cervical cancer and how effective it is. Right. So I am starting with 150 participants, and throughout the duration of the treatment, 10 of them get 10 of them die. And if I exclude those 10 participants from my analysis, so that will lead to and then like 10 of them die, and for example, let us assume 100 of them get cured. Right. So if I omit the participants with the more severe cases, that is those who died, then that would lead to a distorted understanding of the efficacy of this treatment. That is name and bias. If there are still further doubts about the name and bias, I can also see somebody wants an example for interviewer bias. I can post more examples of both of these biases in the group after the session, if that helps. Or did that answer your question, Hafsa? Okay, great. For the interviewer bias, I will give a few examples in the group after the session. Okay, we had finished talking about the different types of measurement bias. Right now, like we talked about reducing selection bias, let us see how we can reduce or how we can deal with measurement bias. So the main way of dealing with measurement bias is blinding. So what is blinding? So it is the practice of keeping the study participants or the researchers or the statisticians unaware of certain aspects of the study. That is that they are not aware of which participant is allotted to which treatment group or which control group. So they don't know if, for example, I am again checking for the efficacy of a new treatment of cervical cancer. So I have two groups, a control group and my case group. And one group I'm giving the placebo drug and the other group I'm giving the new drug. So in blinding, either the participants or the researchers or the statisticians don't know that which patient has which drug. So how does this help? So the purpose of the blinding is to prevent bias in the results by ensuring that there is no preset mindset of any expectations or any behaviors of participants or the researchers, and it doesn't influence the outcome. So it will reduce the placebo effect, it will reduce observer bias and confirmation bias, and it will ensure more objectivity and more reliable results. So, like I said, blinding can be done to the subject, observer, and the analyzer or the statistician. Depending on that, blinding can be a study can be single blinded, double blinded, or triple blinded. So, what exactly is if only the participant is blinded, then it is a single blind study. If both the participant and the researcher don't know the allocation, then it is a double blinded study. Most of the like the good quality or the high level of RCTs that we think of, they are mostly double blinded. And if you want to go even a step further, in a triple blind study, all of the participants, the researchers, and the analysts don't know which participant is allocated in which group. So this is about blinding. Now, let us talk about the third type of bias, that is confounding bias. Confounding bias occurs when an outside factor, that is also known as the confounder, when it influences both the exposure and the outcome in a study. And that will lead to a spurious association or a skewed result. A relationship between two or more causes is observed in a data set, but it is very difficult to tell that how much the confounder contributes to the effect and how much the outcome that the effect that we are studying, how much that contributes to the outcome. In other words, there is a lot of different causes that are mixed together, and it is very difficult to identify the individual impact of each cause. Uh, this could be a bit confusing to understand, so let us try to understand this with the help of a few examples. Right, so this is basically what is the relationship between the exposure, disease, and confounder. What we normally want to study is the relationship between our exposure and a disease. But most of the time, most of the diseases we come across, they are rarely ever caused by a single factor or a single reason. Right? A lot of the time, there are multiple reasons. So another reason that we are not accounting for, that is the confounder. The confounder will impact both the exposure and the disease. And this unknown variable, this confounder, will lead to skewing of the results in a way that we cannot anticipate. This is what is confounding bias. Let us try to understand this further with the help of a few examples. Let us say that study is being conducted to look at, once again, the association between C-section and postpartum depression. But here the confounding factor is maternal anxiety. Maternal anxiety increases the likelihood of both incidence of a C-section and the incidence of postpartum depression. So we cannot, unless we factor in for the confounding variable, we cannot truly say what is the relationship between C-section and postpartum depression. Let us look at another example. Let us look if I want to study the relationship between IUD use and the incidence of pelvic inflammatory disease or PID. Here, the confounding factor could be levels of sexual activity. We know that women using IUDs have different practices and different levels of sexual activity than those who don't. And higher levels of sexual activity can lead to a higher risk of pelvic inflammatory disease. This way, sexual activity levels impact both the exposure and the outcome that we want to study. So, unless we factor in for this confounder, we will not get the true relationship between IUD uses and the incidence of pelvic inflammatory disease. Like we talked about, for selection bias, we have similar methods for controlling or reducing confounding bias. During study design, once again, we can do randomization, restriction, and matching. And during analysis, we can do stratification and multivariate analysis. Can any of you unmute yourself or write in the chat box what any one of these methods mean, or an example of any one of these methods? Very good, Dr. Deepika. Matching we do for age, race, etc. Can anybody else also say what other of these methods mean for reducing confounding bias and also for reducing selection bias? Yes, in restriction, Astha is correct. In restriction, we have inclusion exclusion criteria. Very good. Yes, randomization. So there will be equal likelihood of being included in a group. Okay, great. Okay, so now we will be posting some polls to try and see if you guys understood these different methods for controlling different biases. On your screen's bottom right hand corner, in the when you click on the activities side, you will see a polls written there, so you can click on that and then try to answer the questions as they come one by one. The first question has been posted. And the rest of the questions have also been posted one after the other. They'll appear in just a moment. Did somebody raise their hand? Okay, let us go through these questions one by one. So you guys can we can discuss while answering these polls. Right. The first question says that in a study examining the effect of a new drug on preeclampsia, the researchers do not inform the participants or the doctors which group is receiving the drug and which group is receiving a placebo. What method is used to reduce bias in this scenario? From what all we discussed, can anybody try to give an answer to the first question of the poll? I cannot see the results. So if you guys can see it, I am not
Yeah,
able to
so
take
the
note.
first poll has 8 votes for blinding and 2 for randomization.
Sorry, what did you say?
Um, the first poll has 8 votes for blinding and 2
Okay,
votes for randomization.
okay, great. So yes, the blinding is the correct answer here. Since what we are doing here, that what we do in randomization is, can anybody explain what randomization is and how randomization isn't the answer here?
Hi, may I answer?
Yes, please.
So, randomization just means that a person has equal likelihood of being assigned to the control group or the intervention group. So, in this question, we are not concerned about who gets assigned to which group, but more concerned with keeping that fact hidden from both the patients or the test subjects and the doctors about who is assigned to which group. So, that pertains to blinding.
Amazing. You are completely correct. So that is why this is an example of blinding. Okay, let us look at the second question. A study on gestational diabetes mellitus recruits pregnant women and ensures that the participants are randomly allocated to either the exercise intervention group or the control group. So which technique is being applied here to minimize selection bias? Zainab, can you please let me know what are the results?
So we have all 9 votes for randomization.
Amazing. So like I cannot see who just answered, but like they very nicely explained uh, the concept of randomization. Here we can see that this is a very textbook example of randomization. Right? Now let us look at the third question. In a study investigating the effect of maternal obesity on cesarean section rates, the researchers ensure that for each obese woman in the study, they select a non-obese woman of the same age and parity. So, what method is being used here for controlling the confounding factors? What are the results here?
So we have all 9 votes for matching.
Okay, great. This is absolutely correct. Like you can also see on the screen, uh, here what we are doing is matching because for each patient in one group, there is one or more patients in the comparison group where we have kept a lot of variables same, like the same age and parity. Right? Question 4. In a study for preterm labor, the researchers restrict the study population to only women between 20 to 30 years of age to ensure that age does not confound the results. What method is being used here?
We have
What are
all
the
9 votes for restriction.
Okay, very good. So, like again, you can see on the screen, we are using certain inclusion and exclusion criteria to narrow the range of characteristics. So, this is example of randomization. Next, a study aims to investigate the effect of smoking on preterm birth rate, but the researchers divide the participants into subgroups based on whether they smoked or not before the pregnancy. So, what method is this to control for confounding?
We have all 9 votes here for stratification.
Amazing. That is once again the correct answer since we are dividing all of our participants into subgroups. So, this is the example of stratification. The last, in a study examining the effect of folic acid supplementation on the prevention of neural tube defects, the researchers account for multiple variables like maternal age, socioeconomic status, and folic acid intake to assess the combined effect on the outcome. What method is being used here?
We have all 8 votes for multivariate analysis.
Okay, great. So yes, this is an example of multivariate analysis. Can anybody tell me if I do this study and I only check for the association with folic acid intake and I don't consider maternal age and I don't consider socioeconomic status, so what kind of bias can occur here? Yes, Dr. Deepak.
Confounding bias.
Yes, you are very right. Confounding bias can occur, right? So we are nearing the end of our session. Before we can end, let us once again try to summarize all that we have learned today with the help of this example. Once again, a study is being done to look at the association between prenatal exercise and the risk of gestational diabetes. Right? What is the methodology? So, pregnant women at a maternity clinic were offered exercise programs, of which some volunteered and others did not. So, gestational diabetes was detected by regular prenatal checkups, glucose tolerance test, and routine health records. And the result of the study was that group that exercised had lower rates of gestational diabetes. Can somebody tell me how we can see all the three types of biases that we learned today in this example? Okay, let us go for biases one by one. Can anybody tell me how selection bias can occur in this study?
Is it because there is volunteer bias?
Yes, you are very correct. So, in this study, since people were asked to volunteer, so there is a chance that the women who did end up volunteering, they would have tended to be more health conscious, or they would have tended to have more of a history of some kind of disease like just previous case of gestational diabetes. So that can skew our results. Right? That was selection bias. Now, can anybody tell me how measurement bias can factor in this example?
There can be fluctuations in the anthropometric measurements or weight measurement with respect to time of the day or time of the month, especially.
Sorry, could you please repeat yourself?
There could be some anthropometric changes if we are considering with diabetes, because sometimes we take weight also with diabetes. So certain factors which vary as per cycle or with time duration, they can affect the results during calculation. Even for example, diet we are considering, so diet will also affect the values of random blood sugar levels or whichever measurement we are using for tests.
Okay, so you have given a really good example of a confounding error. So something like diet or something like when we are measuring or with what we are like uh, some other external factor can affect uh, gestational diabetes and it can affect exercise. So that is an example of a really good example of a confounding error, which was going to be my next question. So that's really great. Let us look at if anybody else can try to give an example of how we can have a measurement error in this.
Would there be a Hawthorne bias here because the patients being monitored will possibly have better behavior than the other group?
That can also occur. Yeah, that is also very correct. Let us look at what I wrote for this example. Like you said, selection bias. So the volunteers who are more health conscious, they have a higher risk of signing up. So you can have a selection bias like that. We can have a measurement bias, like we can have Hawthorne effect. But we can also have since they are being examined more frequently, they have a higher risk of they have a better chance of uh, adhering more to the exercise regimen and those who are not being examined, right? And for confounding bias, we can have a confounding factor like diet. We can also have a confounding factor like smoking cigarettes, which can influence the results, right? So we need to factor in for all these confounding factors so that we don't have this bias. Does anybody else have any question in this example or any examples before this, or do you want me to re-explain any other type of bias? Please feel free to let me know.
Wasn't there some kind of bias where the rate of hospitalization or the checkups would be different for the two different groups?
Yeah, that was this thing, uh, Ber- Bergsonian bias.
Bergsonian bias.
Yeah, uh, because of different rate of hospitalization.
Hmm.
We looked at the example between relationship between contraceptive use and incidence of PID. So since more of a like if we only look at the patients in the hospital, then we will miss the chance of looking at the like general population, which will even include the patients who don't have such a severe disease of PID that they go to the hospital or who don't have any PID at all. So that is Bergsonian bias or Bergson's bias. Okay, quick summary. Yes, I just saw. Can anybody tell me what all what were the three types of biases that we talked about today? You can just write one bias if you don't want to, like, if you can't remember all three. Selection bias. Uh, we did randomization as a way to control selection bias. Random bias and systemic bias. Yes, and what were the three types of systemic biases or the three types of systemic error or the three types of biases that we learned about? Yes, selection bias, measurement bias, and confounding bias. Very good. Okay, so just So we did selection bias today. In selection bias, we talked about volunteer bias, we talked about non-response bias, exclusion bias, healthy worker bias, right? Then we talked about survival treatment selection bias. Then Neyman bias, that is selective survival bias or incidence prevalence bias. We talked about Bergson's or Bergsonian bias. This was all the types of selection biases. And we also talked about methods for controlling this bias. Then we talked about measurement bias that included interviewers bias. There was recall bias, reporting bias, attrition bias, or that is because of loss of follow-up. Then there is surveillance bias and Hawthorne effect. Then we again talked about dealing with measurement bias, which mainly included blinding. And lastly, we talked about confounding bias and again ways to reduce confounding bias. Other than this, we also talked about accuracy and precision and validity and types of validity, that is internal and external validity. I hope that answered your question. Other than that, this PPT will again be shared to all of you via your email, so you can look at all of this content at your leisure.
I had one last question.
Yeah, sure.
One of the examples that you gave, you mentioned that mental anxiety can be a confounding factor that equally affects both the incidence of cesarean sections and also the postpartum depression. But how do we exactly check? Because cesarean section in itself can cause considerable mental anxiety leading to postpartum depression, right? So how do we check how it happens, cause and effect?
First of all, it didn't say like it has an equal effect on both of those. It increases the likelihood of both of those things. And secondly, again, if we want to, like as you can also see on the screen, like if you want to take account of some kind of confounding factor, we can do something like matching. So for this particular example, if I want to uh, account for maternal anxiety, then I can do matching if I want to do, or I can do restrictions. So I can give all the participants at the beginning a form for checking their anxiety levels. And if they have high levels of anxiety, I can exclude them from the study. Or if I want to take maternal anxiety into account, I can keep only those with high anxiety into the study. Or I can do matching. So I can keep like those with like I can only keep the ones with low anxiety in the case and control group, or I can keep the ones with high anxiety in the case and control. Does that answer your question?
Sure. Yeah, it does. Thank you.
Okay. Does anybody else have any other questions?
In the meantime, I would also request everyone to just switch on their cameras so that we can take a few screenshots now that we're towards the end of our session. In the meantime, you all can feel free to put your questions in the chat box or just unmute yourself and let us know. Thank you. Also, just to let you all know, I have posted the post-event questionnaire in the chat box. Just to remind you guys that you all can fill this form up till 2 hours from now, and there is a minimum requirement of 70% correct on this. Thank you everyone for joining today. Also, if you all have any further questions, please feel free to reach out to us at research.simsobgyn@gmail.com. And we're happy to respond to any questions that you may have. Thank you very much for joining. Have a good night.